बिस्मिल्लाहिर्रहमानिर्रहीम ला यदुर्रु मअ अस्मिहि शैउन फिल अर्दि वला फिस समा व हुवस समीउल अलीम। सदक़ल्लाहुल अज़ीम। शुरू उस अल्लाह के बाबरकत नाम से जिसकी मौजूदगी में ज़मीन व आसमान की कोई चीज़ इंसान को ज़रर नहीं पहुँचा सकती। आज का हमारा टॉपिक है कोलेस्टिएटोमा। It is a sac of keratinized squamous epithelium which contains keratin debris, and it is present in middle ear cavity. According to Gray's anatomy, another definition is it is skin at wrong place, because keratinized squamous epithelium normally is present in the skin, and it is not normal tissue for middle ear cavity. So there is abnormal collection of this tissue, stratified squamous epithelium, in the middle ear cavity, and it goes on increasing unchecked and uncontrolled like a growth. That is why the word cholesteatoma has been used for this condition. The word oma, O-M-A, is usually applied to benign growths like lipoma, fibroma, hemangioma, and this pronunciation is utilized for a benign growth. But cholesteatoma is a misnomer because it is not a growth. Histologically, it does not fulfill the criteria of a growth. Otherwise, clinically, its behavior mimics a growth because it goes on increasing unchecked and uncontrolled in the middle ear cavity. And because of this property of cholesteatoma, it is responsible for damage to the soft tissues and as well as of the hard tissues in the middle ear cavity and goes on increasing. And ultimately it can be responsible, and it is responsible for intratemporal complications and intracranial complications. The damage which it causes is because of pressure necrosis. So this is very simple definition of this condition given by Gray's anatomy, that it is skin at wrong place. That is collection of keratinized squamous epithelium in the middle ear cavity. It can be congenital cholesteatoma or acquired cholesteatoma. Congenital cholesteatoma is a rare condition very rarely found, but it has got the following features. It has keratinized squamous sac which occurs by birth, as the name indicates. They can arise from anywhere in or around the temporal bone, the petrous temporal bone, where the middle ear lies. There is no evidence of previous otitis media in this condition, and initially the tympanic membrane is intact, and its presentation clinically is characterized by deafness or facial palsy. That is, when it starts collecting in the middle ear cavity and is responsible for disturbance in conduction of sound, it causes conductive deafness, and because of damage to the fallopian canal, it can present itself in the form of facial palsy for the first time, and later on then perforation in the tympanic membrane will take place. So congenital cholesteatoma is a rare presentation, and very rarely it presents in the form of conductive deafness or facial palsy, which may be the only presentation of this condition initially, until it causes perforation of the drum and other symptoms and signs they come up. The common variety is acquired cholesteatoma. And in acquired cholesteatoma, there will be history of otitis media, and there will be posto-superior marginal perforation. There are 13 theories of formation of cholesteatoma, development of cholesteatoma, which we will discuss just now. No doubt the exact etiology of the condition is still not known. First theory is a retraction theory. Negative pressure in the middle ear cavity because of malfunction of the eustachian tube is responsible for formation of a retraction pocket in the tympanic membrane. This retraction pocket goes on increasing in size slowly and progressively. And as you already know, normally the squamous epithelium from the deep meatus and outer surface of the tympanic membrane, which is shed off periodically and is replaced by a new one. That is a normal process. And this shed off epithelium is thrown out with wax in a normal person. It's a normal process. But when there is a retraction pocket formation in the tympanic membrane, this epithelium might be collected in that retraction pocket, not easy to be extruded out by the normal process. So it goes on collecting in that retraction pocket. Superadded infection can also occur in this retraction pocket, and ultimately this retraction pocket goes on increasing in size and may cause perforation of drum towards the middle ear cavity. And so this squamous epithelium, stratified squamous epithelium, is transferred to the middle ear cavity. That is retraction pocket theory. That is formation of cholesteatoma, one concept. The second concept is theory of metaplasia. Normally, everybody is aware of the fact that it is the cuboidal epithelium which normally lines the middle ear cavity. So this normal middle ear lining is replaced slowly and progressively by persistent chronic irritation towards the squamous epithelium, which ultimately keratinizes and cholesteatoma is formed. That is the theory of metaplasia. That is, the cuboidal epithelium of the middle ear is metabolized. There is metaplasia and it changes into squamous epithelium and ultimately is keratinized. And this is how the formation of cholesteatoma occurs. This third theory is theory of invasion. That is, there is a marginal perforation in otitis media, chronic suppurative otitis media. Perforation which occurs in the tympanic membrane is a marginal perforation. Mostly the marginal perforation is present in the posterior segment of the tympanic membrane or in the attic area. Obviously, this being a marginal perforation on one side, the tympanic membrane is missing, and it is only the bony canal which is completing that perforation. From this margin, the epithelium of the external auditory meatus, which is squamous epithelium, that invaginates or ingrows towards the middle ear cavity, and thus it starts the formation of cholesteatoma in the middle ear cavity. This is what you call invasion theory or invagination theory. This is how the cholesteatoma is formed in the middle ear cavity. These are three theories. The exact etiology is not very clear. Now this cholesteatoma, as I have just mentioned, goes on increasing unchecked and uncontrolled. And because of this property, the small middle ear cavity is filled with keratinized squamous epithelium and goes on increasing in size, causing pressure on the contents of middle ear as well as on its walls, and is responsible for pressure necrosis. Complications due to cholesteatoma, they are caused by following mechanisms. Number one, I have just talked about pressure necrosis, which is the most important reason, most important mechanism, most commonly accepted mechanism by which cholesteatoma is responsible for damage to the surrounding soft tissues as well as hard tissues. That is by pressure necrosis. Second is the certain chemicals, they are released from this cholesteatoma and they are responsible for damage to the surrounding tissues. Certain authorities believe that certain enzymes, they are also released in this cholesteatoma and they are responsible for damage to the surrounding tissue. The bacterial infection, superadded bacterial infection, is also responsible for contribution of this pressure, of this necrosis in this mechanism. But the most important and accepted mechanism is pressure necrosis. Diagnosis of cholesteatoma is made by history and clinical examination and also radiological examination, radiological evaluation. History is that of chronic suppurative otitis media, which has got certain special features which we will discuss in the topic of aticoantral disease. Clinical examination with unaided eye may not show you anything special about it except for bad odor, very bad odor, because of necrosis of the bony tissues particularly is responsible for very bad odor. While you are examining the patient, you might feel that quite an ugly bad odor is appreciated while you are examining. You can examine the patient under microscope also, which will show you under magnification the whitish chalky material of cholesteatoma, and radiological evaluation can further be of use. Attic cholesteatoma. In attic cholesteatoma, there is erosion of the lateral attic wall, which is visible in the X-rays, various radiological the evaluations, particularly the CT scan. Erosion of the medial attic wall, erosion of the lateral attic wall, and there is destruction of the ossicles. These things can be very clearly seen in the CT scan or even in MRI. Then there is destruction of the lateral supralateral wall of the middle ear, that is the junction of superior meatal wall and lateral attic wall. An area of translucency can be seen surrounded by sclerotic bone in the normal routine X-ray of the mastoid, can be further confirmed by CT scan, but even in a routine good X-ray you can see area of translucency, which is because of damage to the tissues, surrounded by sclerotic bone. That is, an attempt at healing is also going on by the tissues, which is again a normal process. The treatment of cholesteatoma is always surgical. Some of the authorities, they believe that if it is a well localized small cholesteatoma, you treat the patient medically, treat his infection, and also do repeated suction clearance that might give cure to the patient. But most of the authorities believe, rather it is almost a rule, that it is only the surgical treatment which is recommended for the cases of cholesteatoma, because you have to remove every bit of it during surgery, otherwise it can reoccur like a benign growth. As I mentioned earlier, that as the name indicates, it is oma, but it is not a true growth. On one side, because it does not fulfill the criteria of a growth histologically, but on the other side, it mimics benign growth because it goes on increasing unchecked and uncontrolled. And secondly, the treatment as it is in case of benign growth, that is surgical removal. Treatment in case of cholesteatoma is also surgical removal. It needs total elimination of the entire matrix. And for this purpose, we do modified radical or radical bastardectomy most of the time in these cases. This definition of the modified radical and radical bastardectomy will be discussed in the next lecture, where we will discuss the various varieties of chronic suppurative otitis media. Thank you.